Well, hello. I'm Peter Libby from Boston's Brigham and Women's Hospital and the Harvard Medical School, and it's my pleasure to preside this webinar about inflammation. And I'm thrilled to be joined by Jessica Peña, who's Associate Professor of Clinical Medicine and Associate Professor of Clinical Radiology and Director of Heart Health at the Dalio Institute for Cardiovascular Imaging at the Weill Cornell School of Medicine. So, Jessica, welcome. And maybe you could tell us what we're in store for today.
Well, thank you. It's a pleasure to be here with you today, Peter. I'm excited that we'll be talking about our latest white paper sponsored by the International Atherosclerosis Society entitled Fanning the Flames of Atherosclerosis, Assessing and Managing Inflammatory Residual Risk. Now, this white paper, as you'll see here, there's a link here that you should be able to find for download, had really four sections: the role of inflammation, using biomarkers to identify inflammatory risk, interventions that may help mitigate risk, and really the burden of disease. This was a project that was sponsored by Novo Nordisk, and this is a project really that resulted in this webinar and this paper.
And I would just add that it was supported by an unrestricted educational grant to the International Atherosclerosis Society in order to bring this educational activity to you.
And on behalf of, Dr. Libby and I are co-authors on behalf of this entire writing group, which included Dr. Koenig and Dr. Shimokawa.
So that's the breadth of the International Atherosclerosis Society from Europe through to Asia. And we're in the middle here.
So as an introduction, we all know that cardiovascular disease remains really a significant cause of morbidity and mortality worldwide. One person suffers a cardiovascular event every 30 to 40 seconds. And atherosclerosis is really the primary cause of cardiovascular disease. And really what we'll be speaking of today is recognizing the role of inflammation and understanding how instituting early intervention can lower cardiovascular risk and avert further events. So, Peter, why don't you take us through the development of an atherosclerosis?
Yeah, so this is where I've been living for longer than I care to admit, and that is understanding the biology of atherosclerosis. And this simple figure depicts a very complex process, and we'll get into some of the complexities in the next couple of slides. But it depicts the genesis of atherosclerosis and its complications in a cartoon-like fashion. And it's meant to go from left to right as the lesion is initiated, when we have the little yellow balls that are indicating risk factors such as high low-density lipoprotein, LDL, but also, of course, diabetes and hypertension and smoking and all of the risk factors that you know. We may get into some of the non-traditional risk factors as well. And, of course, we're here to focus on the residual risk when we have taken care of most of the traditional risk factors, and that would be inflammation. That's what we're here to talk about and learn about together. And once we get the process initiated by exposure to the risk factors, the lesion can grow, and it usually grows in an outward fashion during much of the life history of the atherosclerotic plaque. And that's depicted here by the widening of that artery structure with time. And it actually conceals the growth of the atherosclerotic plaque so that people can be incubating this disease without any symptoms or flow limitation through their arteries, notably the coronary arteries. But then we can have, as if it were struck by lightning, a disruption of the atherosclerotic plaque that can incite a thrombus. And that thrombus is shown in the third slice of this timeline from the end as a rupture of the fibrous cap of the plaque, allowing a thrombus to form because of contact of the blood with very thrombogenic material in the middle of the plaque. And then sometimes a substantial minority of acute coronary syndromes and thrombi that lead to flow embarrassment in the coronary arteries is due to superficial erosion, which is shown in the far right slice of this timeline. So the disease marches on with time, is hidden for much of its life, and it is the transition to the dramatic clinical consequences of this disease that preoccupies a great deal in our inpatient practice in the coronary care unit. Now, I'm going to take you on a quick little journey where I have lived for a long time, and that's in the biology, cellular and molecular biology of atherosclerosis. And that's really when we start to drill down and to understand what it is that links these risk factors, which you all can cite, and some of which I mentioned, to altered biology of the artery wall that gives rise to the lesion and its complications. What we discovered was that inflammation is critical and part and parcel not only of the initiation of lesions shown on the left side of this set of cartoons, but also on its evolution and ultimately complication. So what's depicted here is the arrival of unwelcome visitors to the artery wall that has been triggered by exposure to the risk factors. And those unwelcome visitors are the inflammatory cells that are whizzing past the normal endothelial layer shown here on the top of that left-hand figure in blue. Ordinarily, the white cells don't stick to the artery wall, but when the artery wall becomes hot and bothered by exposure to risk factors and through the action of inflammatory mediators that we understand extremely well today on a biochemical and molecular level, it can express, the endothelial cells can express adhesion molecules that can cause the sticking of those leukocytes to the artery wall. And then there are chemokines, other kinds of pro-inflammatory mediators that beckon those leukocytes to enter the intima, take up residence, and then amplify and propagate the inflammatory process. Meanwhile, smooth muscle cells that are usually quiescent or really residing mostly in the tunica media shown there in the middle of that diagram on the left, they can begin to migrate into the intima and divide and begin to give a fibrous character to the plaque. Now, we tend to think of atherosclerosis as an inexorably progressive disease, but in fact, under the hood of the atherosclerotic plaque, there's a tug of war going on. It's actually a pitched battle between factors that push the atherosclerotic lesion, shown in red here, and I'm not going to go through the alphabet soup where I've lived for most of my career with the different mediators. But then on the other side, there are counter-regulatory mechanisms that can quiet the disease, it can put the brakes on. And it's this net result of the pro-inflammatory, pro-atherogenic, and anti-atherogenic factors that lead to the evolution of the lesion, and ultimately, when the battle is lost by the counter-regulatory mechanisms, can lead to the acute manifestations of the disease that can be either thrombotic, such as acute myocardial infarction or many strokes, ischemic strokes, or can be eventually pinching off the flow channel of the artery, the lumen, leading to, for example, exertional angina. So this is just to give you a little bit of a glimpse of how inflammation is important from the very beginning of the process and through its long, clinically silent or stable evolution and up to and including the thrombotic complications that bring the patient to our attention as clinicians most readily. Now, environmental and physiologic factors that increase inflammation. So, Jessica, you've lived in that space for a long time. We were fortunate to have you as one of our cardiovascular fellows, and you did your research, I think probably supported by my training grant, with Dr. Paul Ritker, who was always my clinical partner for the last quarter century, and who gave clinical wing to a lot of the theoretical and basic work which was conducted in my laboratory. So maybe you can take us through this.
Thank you, Peter. Yes, and you'll remember we were just discussing that I became interested in this field after realizing that you could identify inflammation in healthy individuals and that inflammation can predict who would go on to have vascular events. And that really sparked my interest in this field many years ago. We know that several factors are associated with inflammation. Age, so increasing age is associated with inflammation. And then social factors. These are the environments where we live, work, worship, social determinants of health that we're recognizing play a really important role in health and what happens outside of the office and the hospital. Really are associated with inflammation. Stress activates the hypothalamic pituitary axis and increases inflammation. And so we're understanding now that where you live, neighborhood, and what you're exposed to is associated with inflammation, and then lifestyle behaviors, right? Those are also very closely related. So things like smoking, physical inactivity, our diet also interplay with social factors. Other health conditions like diabetes, obesity, of which we're experiencing an epidemic, HIV, chronic kidney disease. And chronic kidney disease is interesting. It's both associated with inflammation, and we know that inflammation plays a role in the development of chronic kidney disease and its progression. And a host of autoimmune diseases, rheumatoid arthritis, lupus, autoimmune, thyroid disease, type 1 diabetes. So really, common conditions that are associated with increased inflammation and cardiovascular risk.
Well, I'm glad that you brought in the kidney disease, the chronic kidney disease, because the American Heart Association has recently embraced chronic kidney disease. And, it's no longer just the American Heart Association, American Stroke Association, but they have a new initiative, which was co-led by one of our former Brigham residents, Chiari Numeli, who's now at Hopkins. And they talk about the cardiometabolic cluster with renal disease. So it's become front and center because so many of our patients, on my inpatient cardiology service, when I rotate, I did a back of the envelope straw poll and kept track of the estimated glomerular filtration rate last time I was on clinical service. And the eGFR was 45, with the normal being above 60. So in our cardiology inpatients, chronic kidney disease seems to be the rule rather than the exception. So we really have to pay attention. I'm glad you roped in that chronic kidney disease.
Yes, and I'm really excited to see our field expanding, beyond cardiology to recognize the importance of kidney disease and metabolic factors, autoimmune disease, really, right? Patients experience all of these together.
So how can we assess inflammation practically in clinical practice?
So I think, thinking beyond LDL, we, for a long time, were focused on LDL, but we recognize that inflammation is a primary trigger, even when we have, we think about other risk factors, like Dr. Koenig explains in this quote. When we think about, traditional risk factors, we realize that there's still a significant proportion of individuals who will go on to have events, and that paying attention to inflammation in that inflammatory burden might cover a significant portion of people who remain at risk. We can use biomarkers to measure that risk. And I think for a long time, we had limited ways to address cholesterol. And I think now that we're living in a time where we have many ways to effectively treat cholesterol, statin intolerance, it allows us to really broaden our focus and think, what are we missing here when we see a patient? What have we not thought of? We have many options for high blood pressure. We of course always start with lifestyle, diet, physical activity, but what are we missing? And so I think thinking about biomarkers to identify risk is important to remember. So, Peter, what do you think is how do we do this?
Well, it was the group in Rome, led by Attilio Masri and Filippo Crea, who really called attention first to the use of C-reactive protein as a way of gauging inflammation in cardiovascular patients. And actually, Giovanna Luzzo was the first author of a famous paper that actually inspired our colleague, Dr. Ritker, to look not just in people who were already sick, but in people who had not had an event and see whether the marker of inflammation, C-reactive protein, might correlate, like looking in a crystal ball for the future of cardiovascular events. And together with a clinical chemist, Nader Rifai, in our medical center, he developed and validated a high sensitivity assay we call HSCRP. It's the same CRP, it's just that the assay goes to the bottom range of CRP. You know, CRP was used in cardiology to measure inflammation in, say, rheumatic fever back when that was a big clinical problem, as it is in some parts of the world still today. But what Paul recognized was that there were deviations in the C-reactive protein within the so-called normal range, well beyond the acute illness or the rheumatic fever kind of CRP elevations that were, as he first showed in Physicians' Health and then in the Women's Health study, were really predictive of new events or first ever events. And, you know, that was about a quarter century ago that Paul started working with HSCRP as a biomarker of inflammation and really led the charge worldwide now. It's been validated all around the world, really led the charge, showing that an inflammatory biomarker was an additional risk factor or additional risk marker that could tell the future of cardiovascular disease in an individual. And, you know, what surprises us is that despite there being, every time you open up a journal, a new inflammatory biomarker being proposed, nothing has really beat CRP. And maybe, Jessica, because you work with Paul, you can tell us exactly why you think that CRP, even though it's not in the causal pathway, it's not a causal risk factor, but it seems to be a very robust and high fidelity biomarker. And what are some of the reasons that CRP seems to have not only risen to the top, but stays at the summit of the biomarkers of inflammation, even after a quarter century? And trust me, we've contributed to trying to find new ones and haven't done better than CRP. Why might that be?
Well, I think several reasons, but as you mentioned, it's remarkably consistent. And I think, you know, for someone who's seeing patients in clinic every day, it's, you know, it's relatively easy to measure. You mentioned the difference between high sensitivity C-reactive protein or what we now call, you'll see when it's reported in many labs as cardiac CRP, so that there's no question that you're looking at cardiovascular risk in contrast to a, you know, quote unquote regular CRP. It's easy to obtain. You know, you'll have results quickly. You can even add it on to a, you know, a specimen if you had forgotten to order it. But you can see here in this table here, it's the risk associated with an elevated C-reactive protein or CRP is linear relationship to relative risk of future cardiovascular events. The blue bars represent here crude relative risks, and the red adjusted for Framingham risk factors. And so you can see this nice linear association with individuals who have CRP levels less than 1, representing those with lower risk. And you can see this, you know, increase in risk really, you know, with levels that are, you know, that are quite elevated. And so, well, you know, like any other test, you know, often when you see a lab value that's abnormal, you'll repeat it to, you know, to be sure that it is elevated, and you want to avoid measuring CRP in cases of acute infection or recent illness. And so it's best done in stable outpatients. But these levels that we see, you know, frequently see elevated levels in practice identify individuals who are at increased risk. And I think it helps, as you said, it's, we know CRP is not likely causally related, but it's like a thermometer. And we can explain to patients, hey, there's this, you know, this element of systemic inflammation that we can measure. And patients often like to see, you know, as they institute lifestyle changes or, you know, lose weight or, you know, do something that they think is in the right direction, like to see that there's something that can be measured that shows that what they're doing is working.
Yeah. So a couple of important points. Let's go back to what Wolfgang Koenig contributed, and that is that even accounting for all the traditional risk factors, there's this huge gap of unexplained risk. And I guess Dr. Ricker coined the term residual inflammatory risk. And that's what is being measured with CRP that goes, as is shown here with the adjustment for the Framingham risk factors, that even when you adjust for all the traditional risk factors, inflammation provides a gauge of this residual inflammatory risk that really is something which has been off the radar screen in terms of our therapies in cardiovascular medicine, even though it seems to be very important, and even more important now that we can drive the low-density lipoprotein into the basement, and we have a whole palette of anti-hypertensive drugs that keep the blood pressure down. So that's really a couple of very important points that we have to keep in mind when we're approaching this. So what can we do about this? As you say, you're in clinic every day. I have clinic on Monday, but I'm a part-time clinician, and you're a full-time clinician as well as an investigator. So tell us what we can do about this in practical clinical undertakings.
Yeah, so I think, of course, measuring it, that's, I think, one of the things that it's a key point. We have to, it's like, we're very facile with vital signs and, thinking about even, expanding our vital signs, including things like waist circumference, but embracing biomarkers and, measuring inflammation to be able to even think about, someone's risk. I'm glad you mentioned this idea of residual risk and dual goals. Like as part of a prevention practice, we were often focused on, managing cholesterol-related risk. But as you mentioned, we know from contemporary trials now that even in individuals who've achieved very low LDL levels, those who have an elevated CRP remain at elevated risk. And so this is a group that requires attention.
Our colleague, Chris Cannon, sort of introduced the term of the dual goals. And by dual goals, he meant, and this sort of came from the analysis that was done in the Prove It trial, that with statins is you not only need to look at the LDL, but also at the CRP. And that the people who did the best in that in many subsequent clinical trials were ones who got both their LDL and their CRP down. So that's the dual goal concept that you were talking about.
Yes, and I think often our conversations for everyone, whether it's primary prevention, or an individual that you're seeing right after, you're in service after who's had an event, heart attack or stroke, remembering the really like the pillar of lifestyle modifications, and really even I think asking about those, asking about diet, asking about lifestyle, asking about how people, get around to where they're going, I think sends a strong signal to people that this is important, no matter what risk level you're starting at. I think people can sometimes think that because they are at such high risk, whether that's genetic or otherwise, that lifestyle modifications don't make a difference. And we know that they absolutely do. So it's important for everyone. And we know that those things lower inflammation. We know that, right, Mediterranean diet, a lot of that, that can be mediated by reductions in inflammation. Treatment adherence. So we have many medicines that work, and we all struggle with keeping our patients on life-saving medication. Pharmaceutical interventions, which we'll talk about, the landscape. And then, of course, we have to remember that there are policy interventions that that influence the behaviors that we're talking about. So thinking about, I guess, at the individual level, some of these pharmaceutical interventions, let's talk about them. So I'll start with statins. That's, of course, the pillar of prevention efforts. People often, when you start talking about statins, will think about the cholesterol lowering effects of statins. We know statins both lower cholesterol and have anti-inflammatory properties. And that was shown, early on in the Prince study using pravastatin 40 milligrams, showing that even, early on, statins reduce levels of CRP. And so I think it's important to remember that when you're having a conversation with someone, these are risk-reducing medications. And so people will often say, well, my cholesterol is fine. And we talk about their risk. And of course, we know from Jupiter that individuals who had CRP above 2, who were randomized to rosuvastatin, had a 44% risk reduction in cardiovascular events, even with what at the time was considered a normal, quote unquote, normal cholesterol or average cholesterol. And then, of course, we now have other exciting developments, interventions.
So, Jessica, you talked about treatment adherence, and I'm sure that you struggle, as I do, particularly in my tertiary quaternary referral outpatient practice, with convincing patients that statins are good for them and trying to keep them with the program. We know that even after an acute coronary syndrome, that a number of prescriptions are not filled, despite best intentions. And if you survey people a year after an acute coronary syndrome, a lot of people who had been prescribed statins are not taking them. So can you give us, in your practice, how do you get people to stay with the program, and what do you do to convince them? I mean, I have to return a call this afternoon to a patient who wants to take a natural way of lowering LDL rather than the statins. So what are some of the tricks that you have for us for keeping people with the program?
Well, I think what I've learned in practice for several years is really starting with the patient and what someone's willing to do, what worries them. And often this is not a conversation that I can have one time. People have to trust you, trust your message. And so sometimes this is a conversation that happens over several months. And I think, often though, I think people eventually are, if they trust you, willing to think about starting pharmacotherapy. But I think it's a particular challenge, especially in young people, people who feel well. This idea of taking medication every day for some, potential benefit, many years later, takes a while to really, to understand. But I'm encouraged. I think many people, because there's more awareness of risk factors and the importance of risk factors, people are, I think, amenable to this idea of, aggressively lowering their risk early in life for primordial prevention and, maximizing preventative efforts early in life. And then, fortunately, we have other agents. And so I think just the idea that we will find something that works for you if you're patient, I think, can assuage people's concerns.
Well, that's very, very valuable advice. And as my friend and colleague, Mark Pfeffer, says, people don't thank you for the heart attack they didn't have or the stroke they didn't have. And if you take someone who's feeling well and tell them that you advise them to take a medication, which if they open up the internet, there's just a cascade of misinformation about drug statins. So we have a gradient of fake news about the statins that we have to overcome. But, the other yellow circles here have intervention that are really focused on inflammation, and they may be less familiar to the audience. Let me step people through this. So we talked about C-reactive protein, and what is it that induces C-reactive protein? Well, it's a cytokine, a pro-inflammatory mediator known as interleukin, IL, interleukin 6. And some very exciting studies are underway using antibodies that neutralize interleukin 6 in various cardiovascular conditions, including people who've had a heart attack, to see if we can reduce recurrent heart attacks by blocking this proximal mediator of that elevated CRP, interleukin 6. And there are also a couple of other clinical trials which have started, one of which is looking at heart failure with preserved ejection fraction, particularly in those who have the cardiometabolic type of HFpEF, heart failure with preserved ejection fraction. And so we have really just in the last year or two cracked the nut of a therapy that actually is effective in people with HFpEF, which is now, as you all know, a frequent contributor to our frequent flyer heart failure hospitalization patients, and also accounts for about half of the heart failure these days, and particularly with the aging of the population and the survival of women into ripe ages is a big clinical problem. And then there's also another study which is looking at patients with acute myocardial infarction to see whether if you dampen inflammation really in the early phase after an acute coronary syndrome, that you might be able to reap a benefit in terms of event reduction. Now, we've talked about how IL-6 is what triggers the synthesis in the liver cells of C-reactive protein. What is it that wakes up the bugler? In other words, who is responsible for inducing interleukin-6? And it turns out that upstream of IL-6, and actually my lab showed this back in the late 1980s or in the 1980s, that another cytokine known as interleukin-1 can induce interleukin-6, which induces CRP. So we have actually a biochemical pathway here where closest to the liver cell that makes the CRP is IL-6, but telling the inflammatory cells to turn on their IL-6 production is interleukin-1. And we designed and executed the first anti-inflammatory study in atherosclerosis, which was called CANTOS, for the canakinumab anti-inflammatory thrombosis outcome study, CANTOS, using an antibody that blocks interleukin-1 beta, one of the isoforms of interleukin-1. And that was actually the first study that showed a reduction in cardiovascular events in people who are really well treated with statins. Actually, in our CANTOS study, we had baseline LDL levels because we really pushed our sites to treat our patients well with statins. The baseline LDL was about 10 milligrams per deciliter lower than in the anti-PCSK9 trials, Fourier and Odyssey outcomes. So we really had a very well treated group with traditional risk factors well controlled. We were able to show an incremental benefit by blocking inflammation. So that was really a landmark. Now, there's all kinds of anti-inflammatory studies, not just the three that I mentioned with anti-IL-6 antibodies, but also colleagues in Cambridge, England, have opened up a program where they're using low-dose interleukin-2, which may be counterintuitive because interleukin-2 is a pro-inflammatory mediator, and it's involved in T cell responses. But it turns out that low-dose interleukin-2 stimulates the efficacy of a subtype of T lymphocytes known as regulatory T cells that are anti-inflammatory. And so we've learned in a couple of preliminary studies that low-dose IL-2 certainly boosts the markers of this special kind of regulatory T cells that are anti-inflammatory and pro-resolution. And remember, I talked about that battle between the pro-inflammatory and pro-atherogenic and anti-inflammatory factors. Well, the low-dose IL-2 may actually work sort of paradoxically to quell inflammation by actually inducing the production of transforming growth factor beta, which is an anti-inflammatory cytokine or mediator. But, the anti-IL-6 antibodies are in clinical trials. We're very interested and hopeful about them. The anti-IL-1 beta antibodies are not available for our clinical practice today because actually in the CANTOS trial, we showed an anti-cancer effect, and the sponsor of that trial is often running, trying to develop IL-1 beta as a cancer drug. And also, we did see a very small but statistically significant in a 10,000 person study with 3.7 years of median follow-up, an increase in infections. So we're seeking the sweet spot here of anti-inflammatory therapy, where we can reduce events through reducing inflammation, but don't impair host defenses in a way which increases susceptibility to infections. So what do we have in our armamentarium today that we can write prescriptions for that can lower our inflammatory risk? And Jessica, maybe you can tell us about what's happened with colchicine in the last few years. An oldie but goodie.
Yes, so colchicine, we all know as an agent usually to treat gout or familial Mediterranean fever. In this pathway that you described, Peter, upstream inhibits microtubule formation and has anti-inflammatory properties, and was studied in large randomized trials, COLCOT and LODOCO-2. And that's led to its approval now at a lower dose of low dose colchicine, 0.5 milligrams daily, for individuals with coronary disease. So this is an agent that we have available now to use. Of course, there's an issue in individuals who have advanced kidney disease or chronic kidney disease, that where there's a limitation, we wouldn't be able to use this agent. But we do have something now for other patients where we're thinking about how to address that residual inflammatory risk, and hopefully we'll have others.
Yeah, now I'm not sure that with colchicine we really hit the sweet spot there, because in some of the large studies with colchicine, there seems to be an infectious signal. We haven't seen a reduction in mortality with colchicine, and some people don't tolerate it terribly well because of some gastrointestinal side effects. But these are low doses that are used, so we can use that today. It was approved, as you say, by the US FDA. More than a year ago. And that's something that we actually have in our therapeutic armamentarium today that can quell inflammation. So something to keep in mind in our patients today. Unfortunately, those colchicine studies didn't stratify by baseline C-reactive protein. So it would be really cool if we could, like we did in the CANTOS study, pick out people who had residual inflammation, that residual inflammatory risk, and target them for anti-inflammatory therapy. So as we move forward in this field, I think we need to use biomarkers such as HSCRP to allocate an anti-inflammatory drug. And we need to show that that's a winner, which we did in CANTOS. And some of the studies that are now in the pipeline, for example, the anti-IL-6 studies, are stratifying people with an entry criteria for the admission ticket to the study is to have a high CRP. So it's really a very exciting landscape because we have a lot of ferment in this area. You mentioned going upstream even from IL-1 beta, and that colchicine can inhibit microtubules. Well, that will block function of some of the leukocytes, which is how it works in gout. But it also can interfere with the assembly of a macromolecular structure that's upstream called the inflammasome. And the inflammasome senses danger and turns on the maturation of two of the pro-inflammatory cytokines, including IL-1 beta, which is first synthesized as an inactive precursor. And so colchicine may be blocking the supramolecular structure that controls the processing of the inactive precursor of IL-1 beta to become active. So there's dozens of different anti-inflammatories that are in development or under investigation, and it's really a very exciting time. I would say that the most mature of these programs is the anti-IL-6, because the study that is looking at that, called Zeus, is actually fully enrolled and underway in multiple countries. And so we're going to get an answer about whether going downstream from IL-1 beta may preserve host defenses and avoid that small but significant infectious risk, including for some fatal infections due to sepsis, but still provide an anti-inflammatory effect. And actually, the pilot studies that we published in the Lancet with Paul a few years ago, that showed that the degree of CRP lowering with the anti-IL-6 antibodies at the highest dose tested was over 90%. And in CANTOS, we only dropped CRP by about 36%. So we're really hopeful that we'll be able to quell inflammation. And by going downstream of interleukin-1, we think that we might preserve host defenses and avoid that infection risk. But boy, the proof is in the pudding, as we've learned, and we need to get the results of that clinical trial to move forward. But some of the challenges with these novel therapeutics is like we're seeing with the incretin mimetics today that are used for diabetes and weight loss, is equitable access. And I think that we all, as a profession, need to militate for ways to get these drugs, get access to people, not just the highly resourced people that come in from the suburbs with their internet printouts, but also to people who reside in hotbeds of cardiometabolic risk and atherosclerotic risk that may be less resourced. And we need to really work on trying to get all therapies available to people who need them on an equitable basis. And maybe Jessica, you can tell us about how we might do that with policy interventions and address the problem at the primordial stage and the preclinical stage.
Yes, I think that's always been an interest of mine. It's very easy to think about the individuals we see in the office, their behaviors, and individual interventions, but we cannot lose sight of the impact of policy interventions and the ability to treat a large number of people at risk with those interventions. And there are, several we could probably talk about, but just to think about a few that we highlight in this white paper are dietary interventions, so things like trans fats bans and sugar sweetened beverages, trying to limit ultra processed foods, and really thinking about that everywhere from restaurants to what we feed children in schools, and then of course the climate. We were living in a time where we are, as Dr. Koenig says, realizing the enormous impact of the environment and factors like air pollution, extreme weather events, and how that relates to inflammation, and then go of course back to the idea of equity. We understand that that these have the potential to really improve disparities. We know that the burden of disease is not shared equally, and poor individuals are often at higher risk, and some individuals, of course, are more susceptible, children and older adults. And so I think these policy interventions we cannot forget to mention.
You mentioned the Prince study, which was perhaps one of the first that showed that statins can not only lower LDL, but also lower C-reactive protein. And eventually, we became convinced that that was independent of LDL lowering, which led to that dual goal idea. I just want to do a shout out here is that the principal investigator of that study was a fellow at the Brigham who you overlapped with, if I remember correctly, Jessica, Michelle Albert, who's now a professor at UC San Francisco and who is the president of the American Heart Association and whose real research interest has been in adversity and in equity. So I'm very proud of the graduates from our program who have really contributed a great deal to raising our consciousness about inequities, but also, like you're talking about, have provided steps forward in solution. And of course, in my role as president of the International Atherosclerosis Society, you have to have a global purview. And it isn't, at the Brigham, I can walk 2 blocks and be in a housing project where all of these issues of equity are put into sharp relief. But we also have to think globally and think about the greatest burden of cardiac disease today resides not in the high-income countries, but in the low and middle-income countries. And so we really need to think about ways in which we can address that. So maybe, Jessica, you can bring us through some thinking about the burden of disease and underscore the point that this is a global problem, not just, when I was growing up in cardiology, we thought that myocardial infarction was a disease of people in the higher income countries, but it turns out that the greatest burden resides elsewhere today.
Yes, absolutely. And this is something we highlight here. Of course, in the United States, $400 billion in annual economic costs due to cardiovascular disease. And we're thinking not just about we're thinking about loss of life, financial burden, not just on individuals, but entire families, our workforce. And so really, when we think about disparities and, economic costs, it affects us all. So it's everyone's problem. And this is, as you mentioned, really a global issue. We're not alone. I think really underscores the importance of trying to, prevent events and earlier in life and really thinking about primordial prevention.
Yeah, that's really a great point. And, one of the promises of the genetic revolution is that we'll be able to use polygenic risk scores to pick out in youth who's susceptible to cardiovascular disease and to begin to institute certainly intensive lifestyle interventions earlier in life so that we can stem this tide of childhood obesity, which is going to really sow the seeds for a global epidemic of diabetes and obesity that we'll pay a price for in cardiovascular medicine. And certainly we know that a lot of the cardiometabolic risk factors, notably obesity, are associated with inflammation. Matter of fact, one of the big drivers of inflammation may be the teeming inflammatory response in certain forms of adipose tissue, fat depots, that could be one of the proximate instigators of this whole inflammatory process that can lead to the activation of the inflammasome, generation of IL-1, then IL-6, and then obviously at the end of the cascade, C-reactive protein, an acute phase reactant. So this really is a global problem, and that's why the International Atherosclerosis Society has a major commitment to trying to address these risk factors on a global basis, not just focusing on our local practice. So in that connection, let me point out to people that we have our triennial meeting, the International Atherosclerosis Society, and that is going to happen in what I'm told is a lovely place in Muscat, Oman, in December. So we would really encourage our audience to think about signing up to go to this conference, which is going to be a wonderful program. And we're going to focus on cardiometabolic disease. And I would say that the Middle East and North Africa region is a hotbed of cardiometabolic risk. You could have a chance not only to learn about all the things we've been talking about in great depth, but also to see, and I'm anxious to do this myself, a new place, Muscat, certainly new for me. And so we would encourage people to think about attending. And we have the early bird registration is still open until September 30th. And there are different categories. So trainees can and nurses or allied professionals could get in at a lower rate than the more mature parts of our community. So consider that. But really, it's been wonderful to work with you, Jessica, on trying to drill down into this new area for many, inflammation, what it is, how we measure it, and then what we might be able to do about it going forward, and how it relates to this global burden of cardiovascular disease, particularly now that we have cheap and readily available medications such as the statins and antihypertensive drugs and aspirin for secondary prevention, which can really be useful for stemming this tide of cardiovascular risk, which shows no signs of ebbing. So we have plenty of time now for some questions. And Jessica, do you have some questions that have come in from our audience?
Yes, thank you. Well, I've enjoyed this discussion with you, Peter, and I'm glad to see some questions here in the chat and in our feed here. So please, if you have questions, feel free to type them in. So I guess maybe a question that might be relevant to others is really what the role of lipoproteins is in the initiation process of atherosclerosis. And I guess just the bigger question of what causes inflammation and, what are the key factors?
Yes, so this is really an interesting and controversial area, and I'm very welcome this question because my cartoons about the initiation of atherosclerosis, including the one that I showed early on in this webinar, and in many of my publications, but all over the world, the cartoons of the initiation of atherosclerosis attributed to LDL. And the evidence actually that oxidized LDL, which is what's in all of our cartoons, is actually the proximate instigator of inflammation, is supported by modest amounts of evidence in humans. There's lots of biomarker studies that show correlations, but every antioxidant intervention that we've tried, including some pretty fancy ones, have failed to reduce cardiovascular events, even when studied in large-scale studies. So here's the wrinkle. And this is another frontier area that you and I are both interested in. And it turns out that the triglyceride-rich lipoproteins, such as VLDL and remnant lipoprotein particles that we measure in clinic by the triglyceride level, that they are much more pro-inflammatory than LDL itself. So really, some of the best data about this comes from Borja Nordestgaard's group in Copenhagen, where they have been able to show that the C-reactive protein, as a measure of inflammation, goes up quite a bit as we increase our concentration of triglyceride-rich lipoproteins, much more than LDL. And actually, work from CENIC, from the Centro de Investigaciones in Madrid, led by Valentin Fuster and Borja Ibanez, show the same thing. So it's been confirmed that triglyceride-rich lipoproteins are more pro-inflammatory than LDL, despite all of the cartoons that I've published and people all over the world. So that's, what do we do about that? So that's another thing. You talked about the Mediterranean diet and how that can have anti-inflammatory effects. So maybe some of that is mediated through lowering the triglyceride-rich lipoproteins. So that's really been a change in our thinking. But as I mentioned, another driver of inflammation is that hotbed of inflammatory activity in visceral fat or ectopic fat. So we know that the male pattern of obesity, sort of the apple distribution in visceral fat, is what is really the toxic kind of obesity, and subcutaneous fat, the pear distribution or gynoid distribution, which is more common in women, is less associated with inflammation. So the role of lipoproteins in initiating atherosclerosis and as a pro-inflammatory trigger is really something that's an evolution. And keep your eye on the triglyceride-rich lipoproteins because there are evolving therapies that may address it.
Yes, I'm glad you mentioned triglycerides, another source of residual risk. And it's our question related to lifestyle modification, what the most important lifestyle modification is. I don't know that there is one, right? I think when you talk about things like triglycerides, you know, the diet we know is really key with triglycerides, but, you know, so that physical activity, you know, reducing alcohol, like these are things that often you have to talk about together.
Yeah, but I think, you know, the founding editor of Hypertension, Harriet Dustin, was a real pioneer because for a woman to make it in academic cardiology when she was active was a real heroine task. And she wrote a wonderful editorial in Hypertension once that said, you have only to check out in a supermarket and look at the headlines in the tabloids, I'm paraphrasing, to understand that for the American public, aside from professional football, what you eat, but not how much you eat, can influence your health. So the point is that we need to think about portion size, and we need to think about, as you mentioned, avoiding empty calories such as sugar-sweetened beverages, which I think are at the root of a lot of the childhood obesity epidemic. And certainly New York was a pioneer in trying to curb some of the availability of sugar-sweetened beverages for youth. And so I think that nutrition and avoiding obesity by both intake and by output, by physical activity is really important. So, we're engineering physical activity out of our communities in this country, in the United States. Some subdivisions don't even have sidewalks. We're so engineered for the automobile. And so get bicycle paths in and sidewalks and encourage physical activity, fight to restore physical activity in the schools, and try to quell the availability of sugar-sweetened beverages, I think could go a long way towards stemming that the seeds that we're sowing for an epidemic of diabetes and obesity.
So I see some questions, I guess, related to genetics, which you mentioned, I guess, briefly. What do you think about the role of genetics in the future for identifying individuals at risk?
Yeah, so, it's interesting that family history, which is something that you can just take off in a few moments in your clinic visit, and that in some practice environments people put it on a pad or on a pre-filled out form. The family history is pretty good at predicting risk because it captures not just genetic complement, but also behavioral environmental issues. So the family that inherits haplotypes together will go to McDonald's together. So there's a great deal of promise. I mentioned polygenic risk scores. I think the polygenic risk scores, it's been hard to show that they actually add that much value to traditional risk factors, particularly when you consider inflammatory biomarkers such as C-reactive protein. But I think when the polygenic risk scores are going to come in handy is where you're talking about primordial prevention. We can take some of, because you look, the polygenic risk score is something you can measure actually in utero, right? And we're born with it. And so even people in the beginning of life, we can assess cardiovascular risk. And that's where we can institute intensive lifestyle modification. So I think that another thing that you and I discussed in the green room was my own current research interest is in something called clonal hematopoiesis, which is not caused by genetic abnormalities you inherit from mom or dad, like the polygenic risk score can capture, but these are acquired somatic mutations that are in a handful of genes that we know can cause leukemia when they're mutated. But it turns out that the cardiovascular risk with these mutations, these somatic acquired mutations in certain leukemia driver genes, actually drive cardiovascular disease more than cancer. So that's another way in which genetics is coming into play in cardiovascular risk.
Yes, I think that'll be fascinating to learn more about. See, so I guess some questions related to lipoprotein A and other biomarkers. I don't know. I think, like HSCRP, LP little a now is recommended for measurement once in all adults and in selected youth. And I think about this as an independent risk factor.
And it's becoming actionable, right? We have a number of therapeutics, including 2 large phase 3 trials which are underway, so that rather than wringing our hands about what to do about high lipoprotein little a, which is a special, particularly atherogenic form of LDL, we may be able to have at hand ways in which we can actually do something about it in the near future, which is a subject for another webinar. Because actually, as exciting and fun as this has been, we're coming to the end of our allotted time for this webinar about inflammation and the use of C-reactive protein as a biomarker of inflammation and how that's leading to ways in which we can actually intervene on patients who are at risk with residual inflammatory risk and improve their outcomes. Today with colchicine, but perhaps tomorrow with some of the agents that are currently under investigation. So, Jessica, it's always great to work with you. And this is a lot of fun. We'd like to thank a lot of people here. We have a very strong AV team that's behind us, and the executive director of the International Atherosclerosis Society, Michelle Winokur, who helped us put this together. and of course to our sponsor who gave us the unrestricted educational grant in order to put this educational program together to you. So send in your cards and letters about what you'd like us to do next. And Jessica, thank you so much for joining. Thanks for the, and there also will be a recording of this. So it will be archived as a memorial to our activity today. So that will be accessible through the IAS website. So thanks to the audience. It's been great fun. And thank you, Jessica, once again.
Thank you.